Welcome to AETCM, the Emergency Medicine channel. Today I'll be presenting a case of 21-year-old female who is a known case of acute intermittent porphyria and came to our ER with complaints of pain in all four limbs and abdominal pain since last 2 weeks. Shall I? On 10-second assessment, patient was conscious and oriented. Airway was patent, there was no secretion. Breathing, patient had a respiratory rate of 18 per minute with a saturation of 99% at room air. Air entry was bilaterally equal and normal vesicular breath sounds present. On circulation, patient had a BP of 130/80 mmHg per and a pulse rate of 84 per minute. And on disability, patient had a GCS of 15 out of 15 with pupils equal and reactive to light. Patient also had a pain score of 9/10, and at this point of time, we had put cannula and given the patient injection PCM 1 gram IV stat. On exposure, patient was febrile and patient had a GRBS of 90 milligram per deciliter. Coming to the adjoints of the primary survey, since patient is a known case of acute intermittent porphyria and patient was complaining of severe pain, we had taken a VBG in order to look out for any electrolyte imbalance or lactate elevation. In the VBG, there was no electrolyte imbalance and there was no acid-base abnormality.
What is the most common electrolyte imbalance you see in acute intermittent porphyria?
Patient will most probably have hyponatremia. They are prone for SIADS. Patient can also develop hypomagnesemia. Coming to the sample history, 21-year-old female known case of acute intermittent porphyria presented with complaints of pain in all four limbs since last 2 weeks. Patient also was complaining of pain abdomen since last 2 weeks and constipation since last 2 days. Since patient was last discharged 2 months back and since then patient was doing well, but since last 2 weeks patient had developed abdominal pain and pain in all four limbs. Patient describes the pain as being crampy in nature and it is aggravated with movements. Patient has graded the pain as around 9/10 in severity and it was non-radiating. Initially the pain was associated with nausea only, but one day prior to the presentation to ER, patient had one episode of vomiting and the nausea was exacerbated with food. Due to the nausea, the patient's food and water intake has drastically reduced since last 2 days. Patient also gives a history of constipation for the past 2 days and she is currently on day 2 of her menses at the time of admission. So coming to the medication history, patient is usually on tab Ultracet whenever she has pain. She has been prescribed tab Ultracet. She is also on tab Duloxetine and Mirtazapine since last 2 years. Coming to the past history, patient is a known case of acute intermittent porphyria and she was detected with the same 2 years back, and her mother and 2 siblings is also a known case of acute intermittent porphyria. It was detected 2 years back when she developed severe abdominal pain, and when she gave a history of red color of urine, they had tested her and then came to be as acute intermittent porphyria. And then coming to the general examination, patient was conscious oriented. There was no pallor, icterus, sinus clubbing or lymphadenopathy. There was local tenderness in the bilateral upper limb and lower limb. And coming to the systemic examination, respiratory system air entry was bilaterally equal. Normal vesicular breath sounds were present. On CVS, S1, S2 was heard. Per abdomen, diffuse mild tenderness was there. There was no palpable organomegaly. On CNS examination, there were no focal neurological deficits.
What are the most common focal neurological deficits that you see with the AIP?
Patient can develop muscular motor neuropathy, so patient can develop weakness of the muscles. Patient also can develop paralysis of the muscles. Respiratory muscle paralysis can be there. It can also involve the peripheral nerves, so they can develop brisk drop and foot drop. Carpal tunnel syndrome is also seen in patients.
So it can affect your central nervous system and peripheral nervous system. Peripheral nervous means sensory and motor peripheral nervous system and autonomic nervous system. And as you told, autonomic nervous system, there can be fluctuations in BP and tachycardia conditions that can happen. So, but that usually is identified in hospitals because patient may not give a history like that. But patient's most common history will be, as we told, motor deficits. Patient will have bilateral involvement of as weakness. The weakness is usually proximal muscle weakness involving upper extremities first, then gradually progressing to distally and to distal extremities. So, proximal weakness worsening to the extremity is the classical features. But in rare condition, as you told, when central nervous system is involved, it can affect respiratory muscles, can cause respiratory paralysis also. That and all is very uncommon because it's not a acute presentation, it's a very chronic presentation. And there are, even though AIP is intermittent episodes, episodic in nature, episodes can be very frequent, which can cause lasting complication. That is how your foot drop and wrist drop develops. So these are the most common neurological deficits that is associated. So when we look for neurological examination, these parts we should look for in the patient. Okay. Then.
So patient was complaining of severe abdominal pain. After giving injection PCM, we had reassessed the pain. Initially, the pain score was 9 out of 10. Even after injection PCM, patient was complaining of a pain of 8 out of 10. So we immediately started the patient on dextrose infusion. Usually in acute attacks of acute intermittent porphyria, the high carbohydrate fluids are advised. So we had given patient 300 ml of D25 mixed with 200 ml of NS.
Okay, so that's coming to management now. So this patient, acute intermittent porphyria, what is the problem the patient is having?
Basically, in the heme synthesis, there will be deficiency of the enzymes which lead to more production of the porphyrins.
Okay, so there is an increased porphyrin levels and porphyrin metabolites in the blood of the patient, isn't it? So in such a case, what are the organs that are most commonly involved?
Basically, liver and the erythrocytes will be involved.
Most common is erythrocytes and liver. Liver is one of the most common reason for neurotoxicity development in the patients. Now, how does a normal, like in whom do you think AIP is commonly seen?
Mostly it is an autosomal dominant condition. So if there is a family history, there is a possibility of developing.
Yes, so screening should be done for patients who are newly diagnosed. But whom do you usually see?
Otherwise, if there
is it a pediatric condition or an adult condition?
Usually a pediatric to adult, that age group.
After attaining puberty only, symptoms usually comes out. So it's more common in adults rather than pediatric age groups. Or even if it is pediatric, it is post-puberty age group is where we get. Females and males usually gets, it's not isolated to one sex as such. How do these patients usually present? What are the presenting complaints of the patients?
Patient usually presents with severe abdominal pain. Patient can present.
Okay.
Then patient will be having nausea, vomiting kind of symptoms.
Okay.
Patient will be complaining of insomnia, anxiety, psychiatric like symptoms patient can develop.
Okay. Irritability, insomnia, anxiety.
In severe conditions, patient can develop with seizures which are not controlled with the usual anti-epileptic medicine.
Drugs. Okay. So here most important feature that we should understand is patient can usually present with nausea, vomiting and non-specific abdominal pain, which patient cannot be pinpointed to an area. Usually it is diffuse and dull pain, persistent pain, right? Progressively increasing pain. So such a pain, this is one of the most commonest presentation of patients to emergency department. So when will you suspect a patient to have AIP?
Patient coming with abdominal pain and we giving analgesics, but patient not responding to the initial analgesics we give. Mostly patient only reacts to the opioids or the narcotic drugs we give.
Yes.
And if the patient is presenting with seizures, the normal anti-epileptic drugs can precipitate more seizures.
Of course, seizure part we can come to. But in a normal acute abdomen evaluation pathway, do you do AIP screening? No. You don't do. So your target population is acute abdomen without a particular organ involvement or particular diagnosis involvement. So you do your routine acute abdomen evaluation pathway, your ultrasounds, blood reports, everything, and everything comes back normal. Then but patient is disproportionately symptomatic. Patient's pain is very much high even though you are given adequate analgesia. And if a patient also has neurological symptoms associated with this abdominal pain, those are the patients you suspect AIP. But this is one of the rarest diseases that we can see in emergency room. First presentation in emergency room is most commonly missed. So it's not very routine disease that we see as such. Here we know patient is already a known case, so we could act much more faster. So this is the presenting complaint that you told. Now, what are the complications?
A patient can go into seizure episodes.
Okay. Yeah, sorry. How does this patient present? Like, why do they present? What are the precipitating factors?
Patient taking any medications which are contraindicated in case of acute intermittent
What
porphyria.
are some of the medications?
Usually drugs like barbiturate, carbamazepines, antibiotics like erythromycin, sulfonamides, then anti-epileptic drugs like phenytoin, valproate, then pyrazinamide, rifamycin, any calcium channel blockers like nifedipine, diuretics like spironolactone, all these can precipitate.
So there is a variety of drugs. But one of the most common drugs that we have to understand is patient NSAIDs, isn't it? NSAIDs is usually not given in AIP. Patients' GI symptoms will worsen, but NSAIDs is one of the most common analgesics that is being prescribed for patients. So that history we have to take. Similarly, seizure history. Patient may present with seizure in emergency, and you loading the patient on phenytoin or carbamazepine can worsen the patient. So a knowledge whether patient is AIP is important. If not, even after loading the patient on phenytoin, patient is seizing, or multiple anti-epileptics, even after giving patient is seizing, we should suspect maybe patient is having AIP. Okay, so drugs are the most common precipitating factors. Any other precipitating factors are there?
If patient has any history of starvation, even mild emotional stress also can be a triggering factor. Other infections, co-infections.
So infections can trigger, emotional distress can trigger, and starvation. That is one of the reasons why we give a high carbohydrate diet for the patient, right? So these are the most common factors that can precipitate a patient. Okay, so once precipitated, as you told, it can be neurological symptoms or with visceral symptoms, or it can be a combination of both. That anyhow we have discussed. Now, even though in ER very rarely we diagnose, how can you diagnose such a patient? Like you are suspecting AIP. How will you diagnose?
During the acute attack, we can take the urine samples and send for bilinogen in the urine. Usually, the normal range will be between 0 to 4 milligrams in the 24 hours. During the acute attack, it can be between 50 to 200. Also, we can send the urine for ALA. The normal range is 1 to 7. During the attacks, it will be around 10 to 100. Then further, if
further testing is out of emergencies, viewpoint. So we don't want to go that much in depth. But this is the primary line of management is urine evaluation for porphyrin presence is what you do. You do either 24-hour urine porphyrin quantitative test or spot urine test. What is the pitfall here?
If the urine is more diluted, then the values what we'll be getting will be error.
So means?
There is a possibility of missing the diagnosis.
Yes, so urine should be collected before treatment. So that is the main problem, because the patient coming to ER, we are not suspecting AIP as a primary complaint. So we may not have urine which is initially taken. We would have already started the patient on some level of hydration and treatment, after which only we will get urine, in which it can be falsely negative. So that is a problem. But the testing should be always done during the attack, not on a OP basis or a asymptomatic time basis, only on symptomatic time. So if you suspect, you should do a 24-hour or spot urine porphyrin level. Okay. So that is the primary investigation. Now, in this case anyhow, luckily we knew patient was positive for the test. Now coming to management, what is the primary management? What is the drug of choice?
Drug of choice is heme. that we give 3 to 4 milligrams per kg on OD basis for 4 days. But
Okay.
usually, since it is very costly and unavailable on ER basis, we go with high carbohydrate fluid given to the patient.
Okay.
And usual protocol is that we take D25 300 ml mixed with 200 ml of NS, making it into a 500 ml solution, which will contain 75 gram of glucose.
Correct.
And that will be given 100 ml per hour, and 4 cycles will be given in one day, making around 300 grams given in 24 hours. So this can be repeated until patient symptoms becomes reduced. And also in along with this, we can give also narcotic drugs for pain relief. Usually the preferred ones are the morphine and the fentanyl. Tramadol we usually does not prefer because it will reduce the threshold for the seizures. So those are the analgesics what we can give.
Okay.
Then on prescribing drugs, we should make sure that all these contraindicated drugs should not be given to the patient. And also in cases of infectious period, that infection should be treated.
Okay.
And during the discharge, patient should be given all the proper vaccinations in order to prevent the next attacks. And if the patient's triggering factor is menstrual cycles, then during the luteal phase, we can give the patient GnRH analogs so that the ovulation can be controlled and that trigger can be
That's taken. Because progesterone is supposed to be a trigger for AIP, right? Increased progesterone levels can trigger AIP. It's not fully proven, but it is a level. Okay. So what are the vaccinations that you are mentioning to be given for the patient?
Usually respiratory tract
influenza and pneumococcal vaccines.
Vaccination.
Influenza and pneumococcal vaccines is to be given. It's not a ER standpoint as such, but once patient is discharged, it can be done. In ER, when patient presents with the AIP, not AIP, like a presentation like AIP, what are the close differential diagnoses that you have?
Usually lead poisoning can be also kept as a differential diagnosis.
Chronic
because
lead poisoning, correct.
The presentation will be similar. Patient will be having abdominal
diffuse
pain
abdominal
and
pain,
neurological
constipation. Patient will have anxiety, memory loss, correct.
Then any liver issues also, neurological symptoms can be caused by liver issues.
Encephalopathy features.
Encephalopathies. Then hepatitis C patients can also have these similar features.
Constipation, abdominal pain, colicky pain with altered mentation, muscle cramps, any electrolytes, hypercalcemia. Hypercalcemia can mimic like this. So these things we need to think about. All these things that we discuss right now doesn't come even in the top 5 causes of acute abdomen. Acute abdomen pathway is completely different. We rule out those conditions, then only we look for these things. When hypercalcemia doesn't come as a most common cause, right? But if neurological deficit is there with abdomen symptoms, as you told, these things has to be looked into with hypercalcemia. Anything else?